Alive on the Moon, Jaro. It's on the pen Alive, with your host David Knapp.
Thank you, Clap Track. Happy Thursday night. I'm Dave Knapp, ManOnMounjaro. That's why I'm here. You are on the pen. That's why you're here. Wegovy, Sexenda, Victoza, Trulicity, Mounjaro, Zepbound, that pen. And that's what we talk about here at On the Pen. I'm glad you joined us. This is the 72nd episode of On the Pen Live. So thank you for being here. If you've been here for a long time, put OG in the chat next to your name. If you are a member of the channel, drop those custom emojis for just $2.99 a month. You also can become a member of the channel. It supports the work that I do, and it gives you access to custom videos, custom emojis, and for my money, the best community on the internet when it comes to GLP-1 medications. But we've got a great show tonight for you. And I really don't want to waste a whole bunch of time with the fluff, because this is one of the most exciting interviews that we've ever done, and maybe that you'll ever hear on the Pen. One of my very favorite sources of information on obesity medicine, and one of my favorite follows on TikTok, Dr. Beverly Tchang, lent some time to the channel this week, and we've got a great interview coming up for you in just a couple of minutes. But let's get to a little bit of housekeeping. In addition to one of the most exciting guests that we'll ever have on this show, we've got one of the most exciting announcements that we've ever made on this show. So something that I've been kicking around for a long time is writing a book, right? And I have plans to write several, but I am super excited to announce that we are very close to releasing our first On the Pen book. This be an introduction or a beginner's guide to understanding GLP-1 medications and how they work. You can see the title there, On the GLP-1 Pen. Kind of putting that in perspective for everybody. If you are excited about this news, drop the book emoji in the comments of this video. Write book if you are excited for this. This is one of the most exciting and fun endeavors that I have taken on this channel, and I'm so excited. What do you think of the cover? What do you think of the cover? My sons helped me design that, come up with the final design as we were tweaking around with it. So it was a lot of fun to come up with that. What an exciting announcement, right? Another one is we talked a little bit about the ways that you can support the channel by becoming a member. Another thing is I wanted to tell you about this. This is a Renpho scale. I shared this with my Zepbound for weight loss Facebook group. We're about 18,000 strong over there. This week, this went on sale on Amazon for $19.99. There's going to be an affiliate link in the description of this video. You can get this as well. What I really like about this, I've had this for a couple years now. I step on the scale and it measures my body composition. So your water weight, your muscle mass, your weight, tracks that all, gives you insights, data for only $19.99. Usually it's around $40. So that's a really good deal. I don't often share affiliate stuff on here, but this one is a really good deal. And I think many of you might benefit from that. If you'd like to get that, you can follow the affiliate link in the description of this video. When I have a guest like Dr. Beverly Tchang on, I like to keep this show rolling. So let me know if you've enjoyed the show so far. Let me know if you're excited about that book in the chat. But while you're chatting, while you're conversing, I want to talk a little bit about what's fresh in the news of GLP-1s this week. So a really interesting article dropped from Bloomberg Law this week. Yeah, Bloomberg Law. This one affects creators, right? But I think that the channel, those of you who watch this, will find this interesting. One of the things that I've always kind of mulled over in my head about the promotion of these medications online by certain influencers and whatnot. I don't personally consider myself an influencer as much as a communicator, a news person, but there are many influencers, especially large accounts, that have affiliated themselves with different telehealth companies, which is totally great, totally fine. But what I've always wondered about is the promotion of specific compound medications and the way that they're talked about by some creators online in ways that would never, ever be allowed from, like, say, a drug rep from Eli Lilly or Novo Nordisk. There's very strict rules by the FTC and the FDA on what sort of claims can be made about medications. And those just seem to not apply to people who are like lay people with affiliate codes. And so I've always wondered how this sort of legal gray area went on. Well, this week, this article in Bloomberg Law that was released basically talked about some new draft guidance being adopted by the FDA, where they are actually going to be monitoring misinformation and information that sort of goes against the grain on what the FTC requires for medication advertisement and sales. And so I think this is really going to affect not only content creators, but telehealth companies. It'll be very interesting to see how this sort of changes the landscape. Again, this doesn't directly apply to, typical GLP-1 news that we would share, but I did think that this was an interesting article. If you have watched an influencer at any point talk about compounded medication and felt like you heard some sketchy information, especially if you're a healthcare provider, drop sketchy in the chat. I know that this is happening because I've seen it firsthand. So I hope that it's a net positive. I know that most of the responsible telehealth companies would agree that they want people who are speaking about the medications to be speaking in an informed and accurate manner and not making wild claims and allegations where they're sort of like unfounded. And so I think that it'll be a net positive thing, but it'll be very interesting to see how that kind of shakes out. Let's keep rolling right to our Take Out the Trash segment. Let's take out the trash together tonight. This is a good one. So we've talked about tirzepatide pills being offered by telehealth companies. We've talked about retatrutide being offered by telehealth companies. It's the wild, wild west right now. This may take the cake for me. Check out this advertisement that I saw on Facebook this week for tirzepatide patches. Tirzepatide patches. You're seeing that correct. That AI drawn lady with what can only be described as a prophylactic looking package in her hand is apparently supposed to be a tirzepatide patch, right? And so you just see wilder and wilder presentations coming. This actually one came from, I believe, a research grade company, so go figure. But that is a fascinating one. Does the patch catch your interest? Drop patch in the chat if it does. That is an interesting one, but that is something that I wouldn't touch with a 10-foot clown pole. Not even close. Folks, please be responsible. It's the wild, wild west out there. Stay tuned to channels like this where we give you good information and just be careful out there. That was a real interesting one. So we've given you the what's fresh. We've given you the housekeeping. We've taken out the trash together. That only leaves one more thing, the part of the show that you're all here for. And frankly, I'm here for it. I've listened to this interview twice myself. You'll notice that this interview was a bit self-indulgent in the sense that I really was asking questions that I have had running around in my own head with Dr. Tchang this past week. And so I'm so excited to bring you this interview. Definitely give Dr. Tchang some love in the chat as we welcome in this week's hot channel. Take it away, Dave. Ladies and gentlemen, I am so excited to bring an interview to you tonight. This is a highly anticipated interview. I don't know if any of you are following me over on the X platform, but I decided about a year ago to be more active on that platform. And I've really come to enjoy X for the conversation that happens between people in the medical community around the topics of obesity and incretin mimetics, and just hearing from the really smart people that are driving the future of the treatments of this disease that we're living with here. And one of my favorite follows is a doctor. Her name is Dr. Beverly Tchang, and she is a triple board certified physician with a focus on obesity medicine. And since 2018, she has been treating patients and training professionals in endocrinology and obesity. She's nationally recognized with her expertise and has led her to experience as an advisor with Novo Nordisk, among other companies, Roe included, entrepreneurs and investors who want to learn about modern weight management. And again, my favorite follow on Twitter. So without further introduction, I am so excited to bring in tonight's
hot channel.
Dr. Tchang. Thank you so much for being here. It's great to meet you.
Hi, Dave. Thank you for having me.
I am so thrilled that you were willing to give some of your time to our community tonight, and I know that they're going to love the conversation that we're about to have. And so I just wanted to right off the bat thank you again for giving some of your time to the stream here.
Of course, happy to be here.
Absolutely. So there's a couple of topics as we were emailing back and forth about what we should talk about. I went the route of just being a little bit selfish, and I had some topics that have really been kind of rattling around in my brain for the last couple of weeks, and something that I really wanted to hear from an expert on. I mean, everything that I share here on this channel, I'm just a guy. I'm always like, I'm just a dude on YouTube, guys. I'm learning with you. And as I'm learning, I'm trying to share and articulate that information out there, but there's so much that I don't know. And so that's why it's such a treat to have somebody like you on. And so the topics that I wanted to get into were sort of like these future treatments of obesity medicine, and especially as it relates to the role of amylin and amylin agonism, because as we look at the landscape of the medicines that are in the pipeline, the next sort of iteration of obesity medicine that we're going to get from Novo Nordisk is CagriSema, which for the audience, it's cagrilintide, which is an amylin agonist, coupled with semaglutide, which is a straight GLP-1 agonist. They've sort of combined these pathways, and they really saw improvement, especially among type 2 diabetics, in the weight loss category and the glucose control. So my question for you is, what sort of is the role of amylin when it comes to weight management?
You're working with a lot of great information already, Dave. The basics, I think you've hit already. Amylin is another hormone. It's another gut hormone. So just like we talk about GLP-1 in semaglutide and liraglutide, or we talk about that other one, GIP, that's in the tirzepatide version. Amylin is just another hormone in your gut. It's actually produced by your pancreas. And it's a little bit different from the other gut hormones, the GLP-1 and the GIP, because on its own, amylin doesn't increase insulin secretion, whereas the other two do. They stimulate insulin production from your pancreas. But what's unique about amylin is that it's actually co-secreted. So at the very same instance that your pancreas is pushing out insulin, it's also pushing out amylin. All of these actually, insulin, amylin, the GLP-1, GIP, all of these gut hormones share in common the fact that they are produced whenever you eat. So that's why we're creating this umbrella term for all of them called nutrient stimulated hormones, or NOOSH, the NOOSH medications. You'll probably see that acronym floating around more and more, because as you see with all of the pharmaceuticals and research, we're looking at all of these gut hormones. We're trying to figure out which one is the best combination for weight loss, for diabetes control, which combination doesn't cause a lot of side effects and can still give us those benefits. So it's going to be a little bit of an alphabet soup when it comes to a lot of these gut hormones.
That is a great way to describe everything that I've kind of learned, is that amylin is co-secreted with insulin, and there's sort of a synergistic effect of the two. So would it be fair to say that if you are deficient in producing insulin, you are also deficient in producing amylin?
Correct.
Okay. So obviously, if somebody is deficient in producing insulin, we kind of know, at least those in this community, we talk about these things. We know that there are some certain physiological things that happen. Obviously, you have an increase in your blood sugar. That is the most obvious one with insulin, because there's not enough insulin there to drive the sugar into the cells, right? How does a lack or a reduction of amylin production, how does that manifest in the body? Is it noticeable? Are there things that you can test for? How does that all work?
I don't think we have a great answer to that. And that's because when we look at exactly as you say, people who don't make enough insulin, that falls under the diagnosis of type 1 diabetes for the most part. And because it's the same exact cell in the pancreas that dies off, you're losing both insulin and amylin at the same time. So it's really hard to separate those two.
Sure.
What
So
we do know as far as what amylin is supposed to do, especially in the realm of weight management, is that it does suppress appetite. It slows down the gut the way that the GLP-1s do as well. And it also works in the area of the brain that controls appetite to reduce appetite. And so in that way, we think that's one of the mechanisms why and how it might cause weight loss.
is it working in the same area of the brain as what we'd call like the incretins, the GLP-1 and GIP? Is it working in the same part of the brain, or is it a different part of the brain that it sort of activates?
There's some overlap. That's also kind of hard to say, because when we look at where are these hormones acting, you have to think about the hormone as this kind of this key working in a lock.
Yeah.
And those locks are actually everywhere. We're really good at figuring out where are the locks. Okay, but we're not, there still needs to be a lot of research about how does the key fit in the lock, what turns the key, what happens when we turn the key and activate the lock and open the door. A lot of those questions still remain.
Yeah.
But we know that there are locks kind of everywhere in the body for amylin, for GLP-1, for GIP, a lot of different areas in the brain. And what's kind of raising a lot of interest is that a lot of those locks are located in the central area of the brain that controls appetite, but also in what we call the dopamine reward system, which controls our motivation and feelings of cravings and reward and those kind of relationships we have with food. There's a potential where amylin might be able to affect that too.
Very interesting. I know that there are obviously studies being done outside of obesity as it relates to addiction with some of the we'll call them the older versions of the obesity and diabetes medications, the incretins. I think of one that's being done, I think by Novo Nordisk for semaglutide and alcohol addiction. And I know just anecdotally, because of the amount of followers that I have, and because my channel is so myopically focused on these medications, it's like, hey, I was going to the casino 2 or 3 times a week, and now I don't even want to go. And so it's just like you're hearing, you know, some of those more impulsive, addictive behaviors that people have had that are outside and unrelated to eating, even sometimes involved in sexual desire and things like that, that has really been sort of tamped down or quieted. We talk about food noise all the time, especially with tirzepatide, right? Like there must be something magical about the GIP hormone or where it acts, that it seems to really initiate this conversation about the volume of food noise. And I think that based upon what I've heard anecdotally, that can extrapolate for some people to other areas of their life. Do you see that in your practice? Do you see people coming in and saying, like, here's what it's affecting beyond my relationship with food? And if so, what are you hearing?
Yeah, it's exactly that. Exactly as you say, it's the food noise. It feels like a switch has been turned off. It feels like they have the clarity to be thinking about other things now. You know, so many of them say that they never realized how much they were thinking about their next meal while still consuming their current meal. And, you know, that's one of the ways this food noise represents. A lot of them experience that same thing with alcohol, just not having interest in it. I'm fine with 1 glass. I used to drink 2 or 3 glasses with dinner. Now I feel fine with just 1. And I think it's such an important signal to pay attention to, because I think people are also wondering if these medications change your mood or have like psychiatric, psychological effects. Do they change personalities? All of these questions.
Sure.
And there's not great science around that just yet. But I think the potential is there when we think about how strong our relationships are with food, what
Mm.
kind of emotional relationship we have with food. And so when we introduce something new like a medication that creates a breakup in that relationship, then yeah, you might feel like a loss of a ex-boyfriend or a frenemy of some sort, where it used to be something there for you all the time and sometimes toxic, but now it's no longer there. So you're going to have complex and feelings around it.
Yeah.
And so I think it's something for us to pay attention to.
Yeah, and oftentimes you'll hear about things like transfer addiction, right? Where
Mhm.
people will feel like they need to replace that dopamine hit or whatever they were getting with that. And I think, again, everything that I share here is from the layperson's perspective. I would appreciate if you're watching this, make sure you hit that like and the bell and the subscribe button. But drop in the comments if there's something that you've been experiencing less of, maybe a habit or some sort of maybe a guilty pleasure that you used to enjoy that's unrelated to food, that maybe these medications have helped you with. I'd be curious to hear from those in the chat. I kind of want to go back to, well, a couple things. One thing about what you just said, it would stand to reason, and you can correct me if I'm wrong, but my understanding of the analogs, right? So when I say analogs, I just mean these medications that are designed to mimic in their molecular structure the native amylin or GLP-1 or GIP and bind to sort of those locks that you talked about. My understanding is that, because oftentimes you'll see advertisements for a supplement, increase your natural GLP-1. I'm sure it's only amount of time, before people understand tirzepatide and GIP and how that differs. And so, increase your natural GIP, your nutrient stimulated medicines, right? Because all you really have to do is stimulate with nutrients, and theoretically you're going to increase the native, or what's the word, endogenous or
Endogenous.
yeah. So hormones. But my understanding is these medicines are like orders of magnitude larger concentration than what you're going to get out of your natural production. Is that accurate?
Yes. The orders of magnitude in terms of activity. Yeah.
So then you talk about how these hormones cross that blood-brain barrier, right? And
To some extent, some of them do. Yes.
And so you're getting a level of activity then in the brain that you're never going to get out of the naturally occurring amount. So it stands to reason to me, just logically, that there would be some sort of effect, on the way that your mind is processing things. And so essentially you're never going to get the same sort of level of concentration from a natural production of these incretin hormones or amylin, whatever it is we're talking about, that you're going to get from the pharmaceutical analogs. That's fair to say.
Yeah.
So,
and
yeah.
What you're kind of getting at there is this idea of resistance in a way. Like we can just, we have these locks in our brain, and maybe we're trying to stick as many keys as possible, but there's just not enough locks there. The locks have disappeared, the doors are completely shut, and we're throwing more and more keys at it, but nothing's opening the doors. That's kind of the idea of resistance. And people are probably more familiar with this idea with respect to insulin resistance.
Right.
Because insulin resistance is one of those problems with the body that precedes diabetes and predisposes you to developing prediabetes and diabetes. But there's also a concept called leptin resistance that I don't know if many people realize. Part of that is because there's still a lot of research going on around it. But the idea behind this is that leptin is another hormone, not gut related, but it's produced by all of the fat cells, all the adipose tissue in your body. And that leptin hormone is essentially helping your brain tell you what your body weight set point is supposed to be. So if your brain can't tell how much leptin you actually have around, then it's going to think that you are underweight and that your body weight set point should be higher. What's unique about amylin, based off of older amylin analog options, is that it actually helps treat some of that leptin resistance.
Very interesting. And I'm sure medical science has tried to, sounds like leptin is something that you would want to block, right? Or is it something you would want to encourage? I'm not sure.
It's a combination. So leptin in of itself tends to be pro-inflammatory. It's been associated with more like inflammation and all of that. So to a degree, you'd want less of it.
Yeah.
And that means less fat tissue, which produces that leptin. But you don't want to block it completely, because then your brain can't tell how much leptin or fat is around.
Okay.
We really want that sweet spot. We don't want complete lack of fat, because if we have no fat on us, no leptin is detectable, then your brain is going to think that you have your BMI is like 10, or you're starving, or all of that, and it's going to rebound, so to speak, and try to get you to gain weight. So we don't want to block it. We just want the right amount.
Yeah, interesting. So that sort of connects the dots for me a little bit. Back a few months ago, I had a nice sit-down conversation with Dr. Michael Albert, who was kind enough to come and lend some of his time to the channel. Was a super interesting conversation when he started talking about set points and how your body is kind of like a thermostat. And so it seems like the leptin part in that analogy, it's like that's the thermostat, or at least that's what's sort of setting it. And so that seems like it could be a real key. So that is kind of a nice segue to what do you sort of see? So obviously we've got the real low hanging fruit, the CagriSema, right? We've talked about that a lot in this community. We've talked a lot about the Triple G, retatrutide, and it's got, its own rivals coming up the ranks in phase 1 trials also. Beyond those, what are some of the different pathways that are being talked about, or that you're personally interested in, that you see as really, kind of the future of obesity treatment when it comes to medicine?
I think you're going to start seeing more focus on what we call peripheral targets. So in science research, when we talk about mechanisms and how things work, we separate it out into 2 buckets, one being central essentially meaning anything brain related, so neurology, brain related, and then peripheral, which is anything out in the rest of the body, not brain.
Sure.
Anything not brain. The GLP-1s, by and large, work centrally. They work in this area of the brain, in the hypothalamus, to reduce appetite. We talk about how GLP-1s also slow down the gut, so it also has what we call a peripheral mechanism. So it has a combination of both. But I would say, by and large, the weight loss effect we see from the GLP-1s and the combination GLP-1 and GIP are central. And probably it's going to be the same thing with CagriSema, with congruentide, also central. In other words, all of the anti-obesity medications that you're seeing now work to cause weight loss by suppressing appetite. So really affecting that energy intake half of the equation.
Sure.
We don't have anything yet to affect the energy expenditure, the metabolism, that burning part of the equation. And that has more to do with what is the rest of your body doing with all of the calories? How does it know whether to store it or to use it up as energy? How does it know where to store it, whether we're storing it in fat, subcutaneous fat underneath the skin, or is it putting it in what we call ectopic places, which is fat around our organs, around the heart, the liver, the kidneys? So that's the type of fat locations that we don't want.
Right.
So a lot of the science is trying to figure out, how do we fix the peripheral use of these of our calories with medications? How do we increase energy expenditure? how do we do so in a safe manner, essentially? So some of these agents, like the glucagon part of retatrutide, might have some peripheral effects of activating our fat to have a higher metabolism. Some of these medications, like bimagrumab, which is it's a unique antibody that actually stimulates muscle growth, has that peripheral effect. And we want to build more muscle mass because muscle also increases your metabolism more so than extra fat or anything else. There are other agents too that are being researched and studied to figure out how do we change the fat that we do have into brown fat. So there's white fat and brown fat, getting more complicated, I know, but there's this idea of browning the fat. Can we make it so that the fat is working harder and burning up the energy that it's storing? That's the basic idea. So I do think that the future of obesity medicine is going to shift their focus into these peripheral targets so that we are really affecting both sides of that energy equation.
And you're saying that maybe the triple G, that adding the glucagon component is sort of like the dipping the toes, and like that's like the first maybe generation of drugs that will hit the market that will actually address that. Of course, you also mentioned bimagrumab, which was an asset that was acquired by Eli Lilly, and they've let us know in earnings calls that they intend to potentially pair that with retatrutide. Obviously, tirzepatide would be probably the first, and down the road, even with the triple G. So you're talking about 4 different sort of, I don't know what the right word is, but 4 different sort of pathways that it's working on.
Pathways is the perfect way to describe it, because when we look at what controls our weight, it's a lot of pathways. It's a lot of different hormones. And this is why, if you go see your doctor and you ask them, can you check my thyroid hormone, right? Is that the reason why my weight is off? Sure, we can check it, but that's just one hormone out of like the millions of hormones that your body is working with.
Right.
And so I do think that to really effectively move that set point, we need to target multiple different hormones, because the body knows that once you start losing weight, if we target one hormone, it's just going to kind of fight back with all the other hormones to try to slow down that weight. So I think that's why we're seeing this trend where you have double agonists or triple agonists and multiple mechanism type medications. When we're combining that all together, we see more and more effect.
Super interesting. I think sort of the future that I envision, and I think that AI could really has the capacity to shift this timetable, right? That's why I get really excited to see all the investments that companies like Lilly and Novo, they got this huge windfall from this generational drug, these generational drugs, I should say. And to see them investing in AI is really exciting to me, because the best thing is that it can weed out a lot of potential duds and can sort of move that process along a little bit faster. But the sort of vision that I see is you go to the doctor, you take a test, and this test, is just this massive panel that's run, and it, you can just tell where people are more deficient, where people need sort of, I don't know, supplementation of analogs, or just a special, unique sort of cocktail or formula that addresses the individual patient. Because the way that I kind of see the landscape now, and again, I'm just a dude on YouTube, but the way I kind of see it is like, the way that our system is set up is you have these medications. Here's a molecule, we'll move it through trials, and we'll see how the masses respond to it. But, when you sit here and you're telling me that there are millions of hormones in your body that, potentially exist, when you tweak one, how it affects the other, and then how each individual person responds to that, then I think is like the big question mark. Because right now, with some people, I feel like, who are getting treatment with the current classes of medications, you're kind of trying to fit a square peg into a round hole. Like you're increasing GLP-1, where really what the person needs is amylin, or I'm just using that as an example. I think tailored treatments are sort of the future, where, you know, I see this because in my own community, I have people who take these medications and they blow the clinical trial numbers out of the water. And there's a lot of nuance there depending on lifestyle factors and things like that. But I mean, there's just some people who respond to the medication so much differently than others. And I think like I'm a great example. The reason I stay so engaged in this channel and so engaged in the pipeline of obesity medicines is that the current generation of drugs doesn't do for me from a weight loss perspective what it does for a good number of people. And so I'm like, what else is coming? What else is out there? And so I think, do you think that we could ultimately see something like that in our lifetime, where you could see tailored, more individualized treatments? Or is it always going to be this, well, you'll get tirzepatide and you'll get bermagramab?
It's going to be a combination, I'm sure, Dave. It's going to be a combination, because when you look at these highly effective medications like semaglutide, average weight loss is 15% from the clinical trials. And that means like about 50% of people will get that 15% or more. So 1 in 2 chance that you're not going to get that 15%. You're going to be less responsive. You're going to be under that. And that means, you know, maybe half of the people who are seen by doctors will be fine and happy with basic, you know, square peg, whatever it is, and that's fine. And then the other half needs a bit more tailored approach. Absolutely. And I think that's just what the system can do, what's pragmatic for the system. I think we do need agents that can work well enough for the majority of people, recognizing that there's always a heterogeneity in response to these medications. And so a percentage of people, that includes people like you, will not be in the majority, will be extra special, and will need extra special tailored treatment.
Extra special is the way that my wife describes me, so I appreciate you use that word.
And we do see that trend. So when we look at semaglutide and tirzepatide, the minimum requirement for saying that, yeah, it's a weight loss medication, let's check that box, FDA approved, all of that. The minimum requirement is it causes at least 5% weight loss.
Okay.
When we look at newer agents like retatrutide, and with the semaglutide, tirzepatide, about maybe 10% of people won't even reach that. So it's good enough for about 90% of people of just 5%. Not a huge amount, 5%, but that's the minimum threshold. But even just 1 out of 10 people won't get that effect from these really great medications.
Wow.
But when you look at the newer agents like retatrutide in its phase 2 clinical trial, so smaller numbers, but still like giving us a flavor of what it might be able to do. In its phase 2 clinical trial, 100% of people hit that minimum threshold.
That's crazy.
100%.
And where else in medicine has that happened? That there was a 100% response rate to a drug?
It's a good question. It's hard to, maybe like Tylenol and pain control. You know what I mean?
Right.
Like Advil maybe and pain control. It's not something that you see a lot. Even when you talk to people who take cholesterol medication or blood pressure medication, kind of these more common ones for chronic diseases, there are people where the blood pressure medication just doesn't work for them. So they got to try something different. Or the cholesterol medication just didn't do what it was supposed to do. And that's just because they have different genetics, a different biology. And that means we offer them a different medication. But this is new for us, that 100% of people will hit that minimum threshold. So again, I think the future of obesity medicine is going to be a combination of a square peg that you can just throw at everyone and it's going to fit for like the majority of people. And it's going to be great and effective and safe. And then there might be 10% of extra special people who will need that extra special tailoring of the medications. And I think that's where we're going to be.
Yeah, very, very interesting. It isn't astounding to hear numbers like that. 100% of the trial participants responded with a 5% or greater weight loss. That is just astounding. And I think, a testament to what you were talking about earlier, where you add that peripheral, pathway, that peripheral weight loss by introducing that glucagon component, and just to think where it could go from there. So I think we touched on just about everything that I had kind of wanted to hear from you on this topic, at least. Is there anything in the obesity medicine world right now that just gets you particularly excited or motivated? I mean, after how many years have you been practicing obesity medicine?
More than I'd like to say. I mean, I've been here in a good number of years. Certainly not as many as some of my tutors and mentors and such. But one thing to remember is actually the obesity medicine field it may feel new for a lot of people, but it's been around for decades. We've been studying this for decades. So I know there are some people who are not early adopters, and I think Oprah was kind of like, why didn't I know about you when you were around? But we've actually been around for a while, trying to understand, at minimum, how does the body regulate energy, right? That's just the first question. It's like, how do we decide what to do with a calorie when we consume it? And then how does that go wrong? When that goes wrong is when we have this disease of obesity. So we first had to understand the energy physiology before we could really understand the obesity pathophysiology. And now that we have medications to treat it, the medications themselves are teaching us more about what that pathology is like. I think one day we may end up going back to your point, kind of like, well, these people have the GLP-1 that's broken, whereas these people actually have amylin that's broken. And maybe we have tests available to us to actually see what a person's GLP-1 activity is or amylin activity is, and really help figure out what that more precise medication regimen should be.
Sure. That to me is an exciting thought. And just a personalized treatment, because everything, I've talked to at this point in the journey, creating content or just sort of communicating what I've learned. I've had the opportunity to talk to some really, really smart people in this space. And that's what you universally hear, is just that it's such a nuanced, complicated disease, the disease of obesity, and even from individual to individual. And so to think about a future that would have treatments that would, I think, I don't get out of this space in medicine too often, but enough to hear, I think oncology would be the only other sort of disease vertical that I hear similar, kind of sometimes things just needed to be treated on more of an individual level. And so to see the conversation in my lifetime just go from eat less, move more, and sort of this moral failing to actually there's some medical science, really compelling medical science that points to, why people struggle with this. And then hopefully in our lifetime see that evolve to somewhere where we could treat this more on an individual basis. Is just amazing. It's just amazing.
I think the right word you used was hopefully. I think that's the thing that I've heard from so many of my patients, that seeing this development, these iterations, generations of anti-obesity medications, our understanding of these medications has really brought so much hope to everyone.
Do you find that your patients in general are, from the obesity side of things, are they coming in with a level of knowledge about these medications that you're not used to as a physician? Or is it, because I just think of what other field of medicine are there, entire large communities online that are just sharing information like this? Maybe they exist and I'm in my bubble, so I don't see it.
No, I hear you, Dave. I think I'm in a little bit of a bubble too, because the people who make it to me, who are willing to wait like my 6-month waiting list to see me, are highly educated. They've done all of their own research. They've watched your YouTube channel, everything. But I always say that information is not education, right? We are surrounded by information all the time, but if we don't have the context, we don't know how it applies to us individually, then it's not really education. It just becomes noise to some extent.
Wow.
And so I always appreciate whenever people like you are putting this type of content out there, or picking our brains to figure out how should we really be understanding this new headline out there. When patients come to me and they say, I read this new paper in New England Journal of Medicine, can you tell me how to understand this? I love that, because I think people want education, not just information.
Right. Right. And that's, you touched on something that I think it gets to the heart of why I do what I do here. And that is just to one of the things that mantras that I repeat on this channel over and over and over is the information that I share is so that people can have more competent and confident conversations with their medical providers, so that they can be better advocates for themselves along the way. Right. And understand the importance of sharing information. Like, your medical provider can only go so far if you're not articulating the things that you're going through and the behaviors that you're engaging in. And all those things are so important to get a well-rounded treatment plan put together with your medical team, whether that's your doctor, your specialist, your pharmacist, whoever that may be. So I really appreciate you, Dr. Tchang, coming on here and sharing some information with us, so that hopefully they can take that information to their doctor and be educated on the right and appropriate plan for whatever they're dealing with. I so appreciate your time today. Thank you for being here with us.
Thank you, Dave.
Pleasure to meet you. We'll talk again. Dr. Beverly Tchang, such an honor to have her in this channel tonight, and to be able to have this conversation with her. I have been such a fan of her Twitter channel. So much of the information that I've learned and the rabbit holes that I've gone down, and then de facto that we have gone down here on the pen, have come directly from her Twitter feed. So make sure that if you're over on X, give her a follow at BevT. Make sure you put the T in there, Bev Tchang MD, or at BeverlyChangMD.com. Please make sure you give her a follow and give her some love in the chat for sharing some time with us tonight. What an interview that was. One of my favorite interviews, probably just because it was one of my favorite conversations. I loved learning from Dr. Tchang about amylin and the role of amylin in weight loss, and this whole idea of peripheral weight loss versus central weight loss. And if that was new to you, put new in the chat. Let me know, because that to me was one of the more interesting parts of the conversation, was that the whole concept of the current class of medication sort of acting in the brain, and then the other one sort of acting on the metabolism and the rest of the body, and that sort of being the catalyst for the higher level of weight loss. I'm sure many of you already had connected those dots, but to me, that was an interesting way to sort of differentiate between the current generation of medications and the next generation of medications. I really also love the conversation about the future and the possibilities of individualized treatments, because I think that is what so many need, including myself. What a great conversation. What a great show. Thank you for being with me tonight on this excellent 72nd edition of On the Pen Live. And you all have been such a great support to me. I hope you're having a great summer. I hope you're having a great week. And I hope that you do have a great weekend coming up here. Until next time, may the Lord bless you and keep you. May he make his face shine upon you and be gracious to you. Have a great week. Thank you, friends, for being here. I can't wait to do it again. We'll catch you on the next one.